Thank you. I'm Anastasia. I'm a second-year internal medicine resident here at Cottage. And like Dr. Freed mentioned, I'll be presenting on the impact of precordial thump. So to start, I thought we would go to the gold standard of medical TV depiction, Grey's Anatomy.
Good, oars ready. Let's take him up Yang. Here with me, Torres, Adamson. We'll call you when we're ready for the theme.
Roy, your whole crew's in the waiting room. We'll see you after, okay? They're saying you're a hero.
Tell him I'm sorry. Tell him I'm so sorry.
What's he talking about? I have trauma too.
Roy, he's fine. He's gonna be...
I was at the window. I could feel his fingers in my hand. I went to pull him out and I missed a step. What a stupid mistake.
Yeah, you fell, Roy. It was an accident.
It was burning.
B-Tech, no pulse.
Start CPR, bagging. Which one would that be?
Charging at 200.
Or that works too.
Thanks. Had it.
But I'm more realistic.
Yes, it's a little less time. But the myth I wanted to discuss today was if precordial thump should never be used as an effective resuscitative strategy in cardiac arrest. So what is precordial thump? So as we saw in the video, Dr. Christina Yang lifted her hand about 20 centimeters above the patient's chest, and with the ulnar edge of her hand and in a tightly clenched fist, she lowered it to the sternum with about 2 to 10 joules of mechanical energy. And the theory behind this is that this mechanical energy would convert into electrical energy and provide a pacing or defibrillating energy whereby the ventricles are depolarized and in cardiac arrest. There is kind of a subset called precordial percussion, which we actually saw in the first video, which has multiple thumps of lower energy and is used as a pacing device, which we'll get into a little bit. But if we look at the physiology, I've kind of outlined here the cardiac action potential lined up with the QRS that we see on the EKGs. And basically, we're trying, with the cardiac thump, really trying to create this initial vertical line, this depolarization in the cardiac myocytes that correlates with the Q wave, allowing for depolarization of the ventricles and electrical activity. So a little bit about the history of the precordial thump. It was first described by Dr. Schott, who was a German physician in the 1920s, when he discussed it in the context of in asystole in syncopal episodes such as Stokes-Adams, which is basically a syncopal episode with cardiac arrhythmia with complete heart block. It was described again by a cardiologist named Albert Hyman in 1930s, where he was using needle stimulation of cardiac myocytes that provided an electrical stimulation and thus also restarted asystolic hearts. But really it was popularized by a study coming out of Harvard, Pennington and Lone, who looked at chest thump for the first time in the setting of ventricular tachycardia. And they looked at 5 male patients with ischemic heart disease with 12 episodes of ventricular tachycardia. And in the first patient, who was a 49-year-old male, he was initially admitted with VT, initially underwent cardioversion, and then 4 days later, after cardioversion, went back into VT again. He was sedated at that point, given a precordial thump, which you can see in the first rhythm strip here, where you have ventricular tachycardia, then the chest thump, and was brought back into normal sinus. Interestingly, about 8 days later, he went into VT again and actually self-administered 2 blows, which were not successful. Another blow by a physician, again, not so successful, so he was sedated again, had a precordial thump, which brought him back to normal sinus. In another case that they kind of investigated, a patient was resuscitated from ventricular fibrillation, or VF, and had subsequent 18 episodes of VT that was unresponsive to IV lidocaine. The first 6 episodes were reverted by thump, and the last 12 episodes by cardioversion, but in one case, they showed ventricular tachycardia that was actually thumped into a faster rhythm. So on the bottom rhythm strip, you can see VT that was thumped at the first arrow into a faster VT, then thumped again into normal sinus. They also looked at the energies that were created with these precordial thumps during the study, and they found that out of 93% of the VT episodes that they investigated were able to be cardioverted with 10 watt seconds or 10 joules of energy, and that kind of goes back to the initial 2 to 10 joules of force, a much lower energy that is required for ventricular fibrillation that we use in ACLS, which usually starts around like 200 joules. When we look through the literature, honestly, I found a lot of studies that were really for it and a lot that were really against it. So let's kind of go through it. Initially, in the American Journal of Cardiology in 1960, they concluded that the blows to the precordium should be tried even if VF is suspected. So mostly used in VT, but even if VF is suspected. A case study that was published in Chest in 1978 looked at 32 patients with 37 episodes of VT, and 41% of them were successfully treated with mechanical stimulation, either by catheter stimulation or by precordial thump. Another comparative study in PACE, which is an EP journal and published in 1979, also described 22 of 45 episodes of VT that were disrupted by precordial blows. So let's look more specifically at asystole to start. And really in asystole, the literature describes more of a pacing technique or multiple blows to the chest. There is a case that I found that describes a male that went into asystole during surgery, had precordial percussion that was performed until atropine was given, and then ROSC was achieved at that point. A study that was published in 2009 in Heart Rhythm kind of validated this PT effect in asystole in an animal model, the study done at the Tufts Medical Center in Boston. And here, their main objective was to discover about PT in ventricular fibrillation with asystole as a secondary finding. This was an animal model, so they anesthetized and intubated 10 male domesticated swine, placed pressure catheters in the left ventricle via femoral artery, and then recorded 6 lead EKGs for data that was simultaneously recorded with LV pressures. A pacing lead was also placed in the right ventricle, and this was used to induce ventricular fibrillation in this test. Each subject would receive 3 chest thumps after VF was induced. If that failed, they received a 200 joule defibrillation at that point. And if after defibrillation they were asystolic for more than 2 seconds, they would receive a precordial thump. So when we look at this rhythm strips in this study, as you can see on the first strip is your EKG lead, and the bottom is the LV pressure lead that are correlated in time. And at first you can see the VF that was induced at the start of the study. They underwent 3 chest thumps that were unsuccessful. So at this first line here, I don't know if you can see my cursor, you can see the defibrillating shock. This subject was asystolic for more than 3 seconds, and so chest thumps were initiated. And on the top lead, you can see that with each chest thump, there is a ventricular depolarization, and it is correlated with left ventricular contractions on the LV leads. A little further on, you can see that with continuation of these chest thumps, the initial 4 thumps that you can see on the strip, came normal sinus after that. So the results of this study showed that basically in 46 of the 60 VF inductions, 77% became asystolic, so received these chest percussions. The chest thumps were received about 3.7 seconds in, and averaged about 40 chest thumps for each subject in each bout of asystole. And in 46 of 46, asystole reverted to spontaneous rhythm after the chest thumps were initiated. The mean time to recovery for ROSC was 23.6 seconds, and the study looked at about 17,000 chest thumps that were delivered, 83% of which created ventricular depolarizations. So what do we get out of this? The authors of this study concluded that precordial thump can be effective management in the immediate onset of asystole or heart block while IV injections or temporary external pacing pads are being placed. However, it was much less likely to be an effective form of treatment in prolonged asystole and prolonged resuscitation. But how can we be certain? And a lot of people are not. In the Annals of Emergency Medicine, published in 1984, they discussed the AHA recommendations for precordial thump in ventricular tachycardia and basically described them as many anecdotal reports by EMTs when looking at reports in Milwaukee, specifically in out-of-hospital arrests. I found a really great study that was published in 2013 in Resuscitation that basically looked at out-of-hospital arrests in Melbourne, Australia, and they used an EMT registry to look at this, so retrospective. They looked at 434 cases, 103 underwent immediate precordial thump, 325 underwent immediate defibrillation. And what we can see here is this first table kind of represents the initial rhythm change after the initial shock or the initial thump, not looking at any of the other interventions that were done during that time. And what we can see from the numbers, I'll just summarize for you, is that the immediate shock strategy resulted in significantly higher levels of immediate ROSC when compared to the thump first group. Also, many of these thump first group patients proceeded to defibrillation afterwards, which likely accounts for the downtime. In the second table, this represents the rhythm deterioration after shock and thump, which we'll get to in a little bit. But basically, if we take a look closer at the rhythm changes in VF, the shock first group converted to asystole or PEA arrest 7% of the time and 5.2% of the time, respectively. In the thump first group in VF, they converted to pulseless VT 2.6% of the time, asystole 1.3% of the time, and never to PEA. In pulseless ventricular tachycardia, we can see that the shock first group converted to asystole 7.3% of the time and PEA 4.2% of the time, whereas the thump first group in pulseless VT converted to VF 29% of the time and asystole 0 times and PEA 3.7% of the time. What we can see is there is no difference in thump versus shock groups with deterioration to PEA or asystole, and there were fewer rhythm deteriorations from ventricular tachycardia in the shock group than the thump group. This final table looks at ROSC at any time, pulse at hospital arrival, and if they were discharged alive from this hospitalization. And although not significant data, the ROSC occurred in 89% of the shock first group, 93% of the thump first group, respectively. And in total, 70% of the shock first group and 70% of the thump first group were discharged alive from their hospitalizations. So what you can see from these results is that the immediate shock strategy had a statistically significantly higher levels of ROSC than the thump first group. In pulses VT, the rhythm deterioration was significantly lower in the shock first group, and in VF, the rhythm deterioration was significantly lower in the thump first group. So what are the risks of PT? I think first and foremost is deterioration of rhythm. We can see from the studies that we looked at, VT can be converted into faster VT that requires cardioversion. It can deteriorate into ventricular fibrillation, which requires higher shock, or asystole after thump. There are additional risks with rib and sternal fractures. A case report that I found described osteomyelitis of the sternum after precordial thump that actually altered their cabbage plan. But I think, as we know, chest compressions can also have a high risk of sternal and rib fractures, and actually may have a higher risk because they're repeated rather than a single precordial thump in most cases. And I would really be remiss in talking about PT without talking about commotio cordis. So commotio cordis came into the public consciousness in 2023 when Hamlin, a 24-year-old safety for the Buffalo Bills, had a sudden cardiac arrest on the field after he was hit. And really the physiology of commotio cordis is a very fast kind of insult to the anterior chest that physically moves the myocytes of the cardiac myocytes, causing a depolarization due to activation of stretch active calcium channels in the myocardium. As you can see at the bottom rhythm strip, with this insult, it goes from normal sinus to VF. And this happens most commonly in young patients under 35 years old, usually young athletes, with this blunt trauma, and most commonly results in ventricular tachycardia and VF, and is cited as one of the main concerns with PT. But do we see rhythm deterioration with defibrillation as well? The answer is yes. In this study published in 2009 in Resuscitation, it was a retrospective study looking at EP studies in the UK, and they looked at 271 studies, 144 cases of VT, 42 of which deteriorated into hemodynamic instability or cardiac arrest requiring defibrillation. Interestingly, this study looked at synchronized shocks for defibrillator energies, and they found that a shock that was delivered within the QRS had a 93% success rate for converting rapid VT to a perfusing rhythm and 7% chance to convert to VF. A shock outside of the QRS had a much lower success rate at 42% and a higher chance of converting to ventricular fibrillation at 58%. The guidelines right now, the 2022 AHA guidelines for CPR, really mention precordial thump as in a very specific setting, that it can be considered in rescuer-witnessed, monitored, unstable ventricular tachyarrhythmias when a defibrillator is not immediately ready for use with a Class 2B recommendation, as long as it did not delay CPR or shock delivery and found no benefit for routine use in cardiac arrest. So, some conclusions. Honestly, through my literature review, I found quite a bit of conflicting data and a lot of anecdotal, small n's in the studies that were described. But what we can see is this, that for PT to be potentially effective, it matters when and where you do it. It must be done immediately, and it has the highest success in a controlled and monitored environment, such as the ICU or the cath lab. PT also has the potential to create enough energy to cardiovert a heart in a similar mechanism to how we cardiovert now. But it also comes with risks, which is a rhythm deterioration, which is important for this monitored environment, and the rib and sternal fractures that I discussed earlier. So we know that shock is far superior to thump-first strategy, as we can see from the studies, but should thump never be used in a cardiac arrest? That's for you to decide. So do you think that Dr. Christina Yang should have performed a precordial thump on that patient? Do the risks of precordial thump outweigh the potential benefits?
Wait. You got it. Now you're in the hot seat. How many people here have ever done a precordial thump? Just curious. And how many have seen it, either seen it work, either with themselves doing it or watching somebody else do it? I would be in that category as well. So you can see all the older physicians. But there's a reason for that, because they do not teach this anymore like they used to. It was originally taught to do that almost automatically at the first sign of an arrest, and it's not taught anymore. And so the myth, although you saw the current recommendation is under very precise conditions, it can be used. The myth really is what all of you are experiencing, the fact that it's never helpful and you shouldn't do it. And I think, have people been told that or taught that or not? I don't know. Anybody? No? You just have never tried it or just seen it done? Okay. All right, so is it a myth? Precordial thump should never be used as an effective resuscitative strategy in cardiac arrest. How many people think that this is confirmed, that this is true, it should never be used under any circumstances? How many think that it's plausible that it shouldn't be used? How many think that it's busted, that there are times when it is useful or may be useful? All right, I think you got it. All right, we're busted.